This presentation is going to guide you through review of literature about surgical staging of morbidly obese patients with endometrial cancer using minimally invasive technique. This is in the context of our study being published in June's issue of International Journal of Gynecologic Cancer. Although there are many studies listing term morbid obesity in their title, most don't use WHO criteria when using this term. This table lists all the studies that we could find where cohorts of patients undergoing minimally invasive surgery with BMI more than 40 were described. There were only 8 studies. Data excerpted from them are listed here for comparison. First 2 studies don't meet the above criteria. Pavelka study was a benchmark laparotomy study. Gunderson study is an analysis of patients with BMI more than 40 from LAP2 study that introduced laparoscopy to management of endometrial cancer. Unfortunately, in this study, patients who underwent laparotomy and laparoscopy were mixed together, thus analysis of outcomes of laparoscopy in that population is not possible. Furthermore, based on 57% conversion rate in patients with BMI more than 40, laparoscopy can't be considered as a successful method. Considering 57% conversion rate, 2-to-1 randomization, in LAP2 study, there were only 72 successful laparoscopic surgeries for patients with BMI more than 40. To put it into perspective, during 3 years of our study, I performed 76 successful robotic surgeries in this population, which gave me and my team the opportunity to make unique observations and learn well how to manage those patients. In this column, cohorts of patients with BMI more than 40 are listed. N describes total number of patients. MIS describes number of patients undergoing minimally invasive surgery. In the lowest row, results of cohorts from our study are listed. Median BMI in laparotomy cohort was 44, in robotic cohort was 47. Median number of pelvic lymph nodes removed in laparotomy cohort was 19, in robotic cohort was 22. Median number of para-aortic lymph nodes removed in laparotomy cohort was 4, in robotic cohort was 9. That's where the benefits of robotic surgery are demonstrated the most. The study showed that with increasing BMI, robotic cohort had higher number of lymph nodes removed as compared to laparotomy. There was less complications in robotic cohort, including less prolonged intubation. That outcome was not necessarily expected. Here averages for MIS studies are listed. This allows for better comparison to our cohort. In our robotic cohort, 96% patients successfully underwent pelvic lymphadenectomy. On average, in MIS studies, out of cases where lymphadenectomy was indicated, 60% of patients had pelvic lymphadenectomy performed. Median number of pelvic lymph nodes removed was 22 in our robotic cohort versus 11 in other MIS studies. In our robotic cohort, 75% of patients successfully underwent para-aortic lymphadenectomy versus 60% in MIS studies. That being said, only in 4 out of 8 MIS studies, para-aortic lymphadenectomy was performed. If one subtracts results of the Stefan study from University of Iowa, where I was a fellow, there's only 3 studies that list total of 4 patients who underwent para-aortic lymphadenectomy. Median number of para-aortic lymph nodes harvested in robotic cohort was 9 versus 3 in MIS studies. Our complication rate was 22% versus 15 with MIS studies. This is not completely surprising since a lot of MIS studies did not include lymphadenectomy. Those patients had only hysterectomy performed and also had shorter surgery. For example, in Mendivil study, the surgeries on average were lasting 109 minutes as compared to 203 minutes in our robotic cohort. Despite of lower rate of pelvic lymphadenectomy and very few patients undergoing para-aortic lymphadenectomy in MIS studies, the conversion rate was 11% versus there were no conversions in our robotic cohort. For comparison, in GOG Lab 2 study, where all the patients are supposed to undergo pelvic and periaortic lymphadenectomy per protocol, the conversion rate was 57%. Since GOG Lab 2, certainly laparoscopic technique has evolved tremendously, and currently one would expect better results with laparoscopy in this cohort of patients. Unfortunately, there's no studies published that would demonstrate such results. Repetition is very critical for any learning. On average, in MIS studies that are published, there are 7 cases performed per institution per year. In our circumstances, we performed 24 cases per year, and all those cases were performed by one team and one surgeon. In order to accomplish results that we've just discussed, we developed many different modifications. This slide lists 52 of them. Some of them became standard practice by now. Some of them, though, are very unique to our program. This includes adjustments to anesthesia technique, which allowed us to perform procedures lasting on average 203 minutes in steep 40-degree Trendelenburg position, with prolonged intubation rate being very low and lower than in laparotomy cases. Elements of our protocol have not been evaluated separately. Thus, it's impossible to say scientifically which elements are more important than the others. We do believe that all of those elements are very important. Due to a dedicated team that specializes in robotic surgery, including surgeons, anesthesiologists, internists, physician assistants, and operating room personnel, robotic surgery can be a safe and feasible option with a low complication and conversion rate. However, the authors are skeptical that similar results can be achieved in circumstances of low volume practice, even for very skillful surgeons. Ultimately, the cornerstone of the reported success is a teamwork approach with many professionals having adequate repetition to be able to troubleshoot complex and overlapping problems and implement remedial strategies.